Welcome, everybody. I can see people arriving, which is fantastic. Welcome to our first webinar of World Hepatitis Testing Week. I'm just going to wait 1 second, as usual, for people to come in, and then I'll do formal introduction, etc. And I guess apologies, because we are 3 minutes late, which is very unlike us. Normally we're spot on. So the numbers have all slowed down a bit. So I'm just going to say welcome everybody. Thank you so much for joining us today. The first of our World Hepatitis Week webinars. We're super excited that we're able to put a spotlight on hepatitis delta today. One of the hepatitis variants, which isn't often discussed and gets a bit left behind. So really excited to be able to present to have this webinar with you today. So my name's Rachel Halford and I am the president of the World Hepatitis Alliance. I've got a little bit of housekeeping as I open up. So I just want to welcome all our panel first, actually. I'm hoping they're all here. I know that Fumi's been slightly delayed. She should be with us any second, but perhaps we've got Dr. Maria Buti. I wonder if you could introduce yourself, Maria.
Hello, my name is Maria Buti. I am a pathologist. I work in Barcelona in Hospital Universitario Vall. I was the former chair of EASL Public Health, European Association for the Study of the Liver, and I am working for a long time on hepatitis delta.
Welcome. And I think, you know, when I knew I was doing this webinar, I was really pleased because I've got some of my favorite people here today, Maria, Jess, and Dr. Lesi. So really exciting. Thank you, Maria. And Jess, would you like to introduce yourself?
Thanks, Rachel. Hi, everyone. I'm Jess. I'm Senior Director at the World Hepatitis Alliance. And with my team, we lead a lot of the hepatitis delta work. So really excited to be discussing this today.
Fantastic. Welcome. Thank you. And I've just seen Dr. Lesi has just joined us. Fumi, are you here?
Yes, I am. And
would you like to introduce yourself? Maybe we'll come back to Fumi in 1 minute then. So just to do a touch of housekeeping, this webinar is simultaneously translated in Spanish and French. The translation instructions will be shown on the screen, so you should be able to see them. There you go. Just press the button. And I guess just for all our panelists and for any of you that might ask any questions, if you are speaking, please don't speak too fast. I'm terrible for it myself. It makes it really difficult for the people doing the translation. I want to thank Bluejay for supporting this webinar. Really important to thank our sponsors. And I guess just to really open the session, I just wanted to say, you know, that globally, it's estimated that 12 million people are living with hepatitis delta. You know, and although hepatitis delta, we call it hepatitis D, accounts for approximately 20% of the liver disease, access to screening and treatment is largely unavailable. But there are exciting developments in the treatment pipeline, and it's more critical than ever that we increase diagnosis rates and address the existing barriers to scaling up testing. So as a part of this World Hepatitis Testing Week, the World Hepatitis Alliance are hosting this webinar, which is really exciting. And what we hope to do today is to explore the current testing landscape for hepatitis D, the existing recommendations and guidelines, which I think will spark a bit of conversation, barriers to testing and actionable next steps for scale up. So the format is today is that we have our panelists, and then we've got a little panel discussion. We do have an additional panelist I haven't introduced you to, Dr. Tatyana Kushner, who will be joining us just before her presentation. She's from the United States. Then after that, there's an opportunity for you guys to ask questions. So same as usual, there is a Q&A box on the bottom if you want to ask questions. There's a chat box there. Feel free to put any comments in the chat box. We'll be monitoring as we go along. So I guess it's, if Fumi is okay, it gives me great pleasure to introduce you to Dr. Fumi Lesi, who is the viral hepatitis lead for the World Health Organization. And Fumi's going to be talking about the current testing guidelines. So Fumi, are you there?
Yes.
Oh,
Hence-
fantastic. Welcome. And I'm going to hand over to you. Thank you very much.
Right. Okay. Can you see me? Can you hear me?
Yes, we can hear you and see you.
All
Welcome.
right. Thank you very much. So my name is Dr. Fumi Lesi, viral hepatitis lead, WHO in Geneva. And I'm really excited to be presenting today as part of the Hepatitis Awareness Week. And of course, thanking World Hepatitis Alliance for putting this webinar together. So I'm going to talk about the current WHO guidelines and some considerations for implementation. Next slide, please. And I get a lot of questions from people about what is hepatitis D, what is hepatitis delta. So I want to start this brief conversation by talking about general viral hepatitis. People hear hepatitis A, hepatitis B, hepatitis C, D, and E, and sometimes it's called an alphabet soup of viral hepatitis. So the important thing is that these are the 5 main strains. They're all different in relation to their burden, the routes of transmission, severity of illness, the geographical distribution, and of course, the available prevention and treatment options. Hepatitis A and E generally come out in outbreaks. We have concentrated often on B and C. And the second bullet shows that of these, the 2 major strains of hepatitis viruses, hepatitis B and C, are responsible for 95% of the mortality. And of course, we know that we have made a lot of progress in hepatitis B and C, including hepatitis B vaccination, including birth dose immunization. Now, hepatitis D, we have not spent a lot of time on hepatitis D, but we are beginning to note the increasing momentum of action in hepatitis D. It's a small defective virus that requires hepatitis B for packaging. It requires hepatitis B for secretion and for entry in cells. As a result, hepatitis delta, I'll call it hepatitis delta to make it easier and distinguish it from B, it affects people who are already infected with hepatitis B. And again, it shares similar routes of transmission with hepatitis B, including percutaneous blood transfusion, injecting drug use, contaminated needles and syringes, and even among key populations. Next slide, please. So the global prevalence, as Rachel has alluded to, is about 4.5% of the people who have hepatitis B. This is equivalent to 12 million people. I think the main point here is that the geographic distribution is very heterogeneous, and there are some areas of hotspots. We're looking at countries like Mongolia, which is in bright red on this map. And this has the highest population prevalence that has been estimated. Other countries like Moldova, and then some countries in Western and Central Africa, some in Central Asia, and of course in Eastern Europe, some Pacific islands, and again the Amazon basin are areas of hotspots for hepatitis delta. Next slide, please. So I have a question here. So why does hepatitis delta, why does it matter? It matters for many reasons, but I've highlighted 4 reasons here. 1, the burden, which we talked about. 2, it's the most aggressive form of viral hepatitis because it causes an accelerated progression to liver cirrhosis or liver cancer compared with hepatitis B alone. The data and the evidence shows on the right side that 1 in 6 of cirrhotic cases and 1 in 5 of liver cancer are among people with chronic hepatitis B. So if we look at the math, if we take hepatitis B generally, 1 in 20 of hepatitis B infected individuals have hepatitis delta. But if we look at the end results and the complications, there are more people with complications that have hepatitis delta. Now, some factors associated with progression includes what we see on the screen. So reaching the WHO targets for elimination, for reduction of mortality will require scaling up the hepatitis B risk, the hepatitis delta response. Next slide, please. And WHO guidance is available for hepatitis B and C because of its unique characteristics to public health. Next slide, please. So the next slide shows that hepatitis B testing and treatment guidelines, and WHO has guidelines on how to test for hepatitis B. And I put this hepatitis B slide first because testing for hepatitis B is the first step to testing for hepatitis delta. Next slide, please. The next slide shows the WHO recommendations on who to test, highlighting 2 different approaches for testing. The first is testing all individuals who are hepatitis B surface antigen positive. This has been a conditional recommendation and a lot more data is required for this. The second option is the focused risk-based testing. And this is in countries or in regions where universal testing is not feasible for various reasons. It's possible to identify some risk factors, including people from hepatitis D endemic countries, like I mentioned, people who have advanced liver disease because they have a higher risk of having hepatitis delta, and also people considered to have increased risk of delta, like hemodialysis recipients, people living with hep C or HIV, people who inject drugs, and various other populations. Next slide, please. So, recommendations on who to test. What I want to highlight here is the observational study from some countries that do this testing show poor testing uptake for delta, poor case finding based on the risk-based approach. So there is value in a universal access approach, but there are no studies that have directly evaluated the impact and cost effectiveness of universal testing versus risk-based testing. Next slide, please. Now, WHO also goes as far as to recommend how to test. So we recognize that using a serological test kit to detect anti-hepatitis delta virus is important, followed by a nucleic acid testing to detect the DNA, or sorry, the RNA of hepatitis delta. Now, this reminds me of hepatitis C, where we first test for antibody and then confirm viremia with the nucleic acid test. So similar to the 2-step process for hepatitis C, the hepatitis delta algorithm also follow a 2-step process. And I've tried to show that on the chart on the left, such that testing is firstly in people who are hepatitis B positive. Now, if they have antibodies on this left side, then the DNA testing is done. And where the DNA is positive, and I've written positive, 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 these are the people that have the virus infection. About 60% of people who have antibodies have RNA in serum, but this is higher in high-risk populations. Next slide, please. Now, Again, how to test. This is a strategy that has worked in hepatitis C and also is being deployed in hepatitis B infection. And this is reflex testing. And this is reflex testing of antibody followed by hepatitis D virus RNA. So a triple reflex testing will be in people who are hepatitis B positive, can be tested for antibodies, and then those who are antibody positive can be tested for RNA testing. And of course, this is an approach to strengthen the linkage to care. Now, the evidence for this recommendation is shown on the right with systematic reviews that show the benefits of reflex testing in hepatitis delta. Next slide, please. So looking at the considerations for implementation, how operational can these testing guidelines be, given the challenges we have with testing? And I've highlighted some of the challenges. The low hepatitis B testing is an impediment to really rolling out hepatitis D testing. And of course, implementing hepatitis delta is going to be challenging in many settings, including low-income countries, where most of the testing is done using rapid diagnostic test kits. So the lack of availability of rapid diagnostic test kits for hepatitis delta will certainly be an impediment to scaling up and implementing these recommendations. And of course, the diagnostic laboratory capacity and the resources are important. And the need for RNA testing, that is molecular testing, is of course a potential challenge to scaling up and availability of the test. Then, after testing, the lack of effective treatment for hepatitis delta presents an important ethical challenge, and I think we'll hear more about this from other speakers in the presentation. Now, my last slides are, next slide, please. And in terms of what are the next steps, the next step, it's important to expand access to DNA testing and treatment, but key barriers that need to be overcome include the awareness. Many people do not even know about hepatitis delta. Even persons who live with hepatitis B themselves do not know about hepatitis delta. The availability of norms and standards and more products are critical to overcome to improve access. The quality of the test kits and the DNA requires standardization and regulation. Now, in terms of affordability, all of these become important for public health response. And of course, equity, addressing the needs of vulnerable populations. And there are multiple research gaps in the area of viral hepatitis delta, which we can discuss later. But just a commitment that WHO continues to monitor the outcomes of ongoing hepatitis delta treatment trials, and we are considering formal treatment recommendations when further evidence becomes available. Next slide, please. And in summary, it's a significant public health problem with a high mortality in people who have hepatitis B. The hepatitis D is being increasingly highlighted by not just WHO, but all other institutions that work with hepatitis and hepatology. And stakeholders and countries are highlighting and are demanding the need for additional recommendations for evaluating better treatments beyond the previous interferon. So there is a need to develop the diagnostics and treatment that are affordable and can be implemented in the low-income countries. And on that note, I thank you very much. I thank the team at WHO Hepatitis in Geneva, throughout the regions and in the countries. So thank you very much, Rachel. We are available for questions, and I hand over to you. Thank you.
Fantastic. Thank you so much, Fumi. I mean, absolutely brilliant. And I particularly liked the really thorough breakdown. We don't hear it very often, the differences between A to E, you know, and I think it's really important. But, you know, I think, as you made very clear within your presentation, it's really concerning. You know, the lack of testing that's already happening around hepatitis B. We know the prevalence is high. You know, this is really concerning. So it's going to be really interesting in some of the later presentations when we hear about how this is translating on the ground. But first of all, and I will come back, Fumi, we do have some panel questions a little bit later. I'm going to move across to Jessica Hicks. We're going to talk, who's going to present on addressing the barriers to hepatitis delta testing. And Jess will be providing some insights from the World Hepatitis Alliance Hepatitis Delta Landscape Survey that was completed, I think it was last year. I'm going to hand over to you, Jess. Thank you.
Great. Thank you so much, Rachel. And you're absolutely correct. We did send the survey out at the end of last year, and we launched the results earlier this year. And really what we wanted to do was generate data that address some of the knowledge gaps and some of the better understand some of those barriers that Funmi just mentioned. And so we gathered views on 3 primary research questions. The first around levels of awareness amongst key stakeholders. And this was specifically focused on healthcare professionals, policymakers, and community-based organizations. The status of Delta testing and treatment, both availability and accessibility, and then what was stakeholders identifying as barriers. And that's really what I want to focus on today. So if we move to the next slide, and this survey, we were able to deliver with the support of Via Biotechnology, and we were delighted to receive just under 600 responses from over 102 countries. And you can see here the breakdown of who responded. So 45.2% were healthcare professionals. Then the next largest group were community-based organizations, followed by policymakers. To note here, when the other respondents, they were predominantly advocates, people with lived experience, students, researchers. So we had a real mix of people responding to the survey. And if we move to the next slide, so I didn't include a slide on this, but because Funmi rightfully pointed out that awareness is a huge barrier, and that is something that came out in our survey responses as well. You know, just under half of community-based organizations, respondents from community-based organizations, noted that they were either not at all familiar or slightly familiar with hepatitis delta. And we also had 1 in 6 healthcare professionals say that they were not at all familiar with hepatitis delta. And given these are sort of 2 core groups that people would be looking to get their information from, we really feel that this is quite concerning and something that the Alliance is looking at how we can better address moving into next year. But just to touch briefly on availability of Delta testing, and 58.8% of people responded it was available, but this figure drops down considerably when we asked about the accessibility. So not only was it available, but could the people that need it access it? And as Funmi said, really, Delta testing has to be spoken about in the context of hepatitis B testing as well. And so we also asked about the availability of hepatitis B testing, and you know, the overwhelming majority of respondents reported that testing is available in their country. And so I think this illustrates on a small scale exactly, you know, that the testing recommendations, especially reflex testing and universal testing for all those living with B being tested for Delta, as the WHO recommendation set out, is just not happening in practice. So if we move to the next slide. So we really wanted to focus down on what the barriers to testing were. And strikingly, 1 in 3 respondents across all stakeholder groups did not feel sufficiently informed to identify barriers to hepatitis delta testing. And this is particularly striking when you look at who actually was responding to the survey. So of the community groups, more than 50% were groups that are currently working within viral hepatitis. And 50% of healthcare professionals were either gastroenterologists, hepatologists, infectious disease docs. You know, these are all people that we would expect to be highly informed. And so the fact that 1/3 of people didn't feel that they had enough information to even identify barriers to testing is quite telling in terms of how much gap there is in terms of lack of awareness. But if we move to the next slide, this sort of, again, came out very strongly that the general lack of knowledge about hepatitis delta testing was 60.9% as identified as the #1 barrier to testing. But then we also had, and this picks up on Funmi's point around costs, that direct costs to individuals was rated as a very high barrier. So looking at the cost of the test itself, then treatment, doctors' fees, but also lack of knowledge amongst healthcare professionals came out quite strongly as a barrier, and lack of public health policies. And then difficulties linked to health facilities, so distance, waiting time, obtaining an appointment. And this also, I think, links in with some of what Funmi was saying around the need to have molecular testing. And, this isn't something that has to date been fully decentralized. And so that does create a barrier. And if we move to the next slide, we sort of look at the breakdown. If you click again, and again, thank you, of the comparison of the different barriers by group. And what's interesting is that for the most part, community-based members and healthcare professionals identified fairly similar barriers, both identifying lack of knowledge, direct costs, and lack of knowledge of healthcare professionals. And, this knowledge around healthcare professionals came out when we looked at training requirements of healthcare professionals. So in nearly all healthcare professionals, really, as part of the survey responses, said that they would like more training across testing, treatment, the pipeline, and also that only about 1 in 10 had received training that they felt was adequate. But interestingly, policymakers did have slightly different responses. And what was quite telling was around stigma and discrimination in the healthcare settings, where, almost 20% of community-based members felt stigma and discrimination was a barrier, 7.2% for healthcare professionals, and no policymakers noted this down. And again, the same with opening hours not compatible, where 0% of policymakers. So there is sort of a bit of a disconnect there between maybe the reality that people living with Delta and community-based members and healthcare professionals are seeing, and what policymakers feel are the priorities. And so that's something else we need to address, is ensuring that policymakers are aware of the barriers on the ground and that they're addressing policies to address those. And just moving to the final slide. So this was some of our calls to action, and a lot of them really do focus on testing, including increasing availability and accessibility, and addressing direct and indirect costs of both testing and treatment. We also are calling for adoption of WHO recommendations on reflex testing, and then looking at sort of issues around training, around providing people with culturally competent awareness campaigns, and looking at skills building programs for community-based organizations so that they're better able to advocate for policymakers and public health officials to improve access to testing and then treatment and care. And so with that's my final slide. So thank you very much, and looking forward to the discussion later.
Thank you, Jess. I don't think there was many surprises in there, but I think it's an incredible piece of work and it's a really good starting point. But it really gives me pleasure now to introduce, so that we can actually hear what's happening on the ground. So it gives me great pleasure to introduce Professor Maria Buti, who is going to do a country spotlight and tell us, what's happening in Spain in terms of testing and treatment for hepatitis delta. So over to you, Maria.
Thank you. It's really a pleasure to be part of this panel. And I would like to talk on Spain. Spain, it's a country located at the south of Europe, and it's very active in terms of viral hepatitis elimination. Next slide. We know that the prevalence of hepatitis delta in Spain in HBs antigen positive individuals, it's about 5%. These are data collected for the National Registry of hospital discharges from the national health system. With this data, next please, we also evaluate the prevalence and the associated comorbidities, because I think it's important not only to look at the virus, also to look at the patients. And we have estimated a mortality rate of 20%, and patients with hepatitis delta compared with those with hepatitis B have more comorbidities. That means more hypertension, more diabetes, more factors associated also to disease progression. In addition, next, we evaluate the presence of these comorbidities and the impact on hospital admissions, days in the hospital, number of admissions, and number of readmissions. And we can see here in orange, patients with Delta have more days stay in the hospital, more number of admissions and readmissions than those co-infected, or limon-infected, sorry, with hepatitis B. Thus, translates in the mean annual cost of hepatitis delta patients is 91% higher than those co-infected with hepatitis B. So there is not only a disease burden, it's also an important economical burden. Next. We introduced in Spain the reflex testing 4 years ago. Started in Barcelona in my center. At that time, we did a retrospective analysis looking at the proportion of patients with hepatitis B tested for Delta. And we found that a very low proportion, only 7% of those infected with B were tested for Delta. For this reason, we implement reflex testing. Fumi has explained very well what is reflex testing, and we increase the testing rate to 93%. That means that the majority of patients visited in 2021 in our hospital and the primary care centers related with my hospital were tested for Delta. Doing reflex testing, we identified 2 important factors. One, it's a 5-fold increase in the diagnosis of hepatitis delta. And for me also very important, 60% of patients with hepatitis delta didn't report risk factors, probably due to stigma or because in some cases they were not able to identify any risk factor. Next. The second question was, is reflex testing cost effective? And in this study, we show that it's cost effective. Early diagnosis and early management of patients with hepatitis delta avoid complications, progression to liver cirrhosis, decompensation, HCC, and liver-related death. So that means that reducing all of these complications with reflex testing results in saving of approximately 36 million euros, and showing clearly that reflex testing is cost effective. Next. So reflex testing has several advantages, such as reduction in patients' loss during screening, more effective communication of results. In only one visit, we can communicate the patients the results, faster access to treatment, and optimization of health care resources. Next. In addition to this, we established in Spain a multi-center registry for patients with hepatitis delta. This was due to the work of a Spanish Association for the Study of the Liver, and we started in 2020 2022 and include voluntarily all patients with hepatitis delta. Up to now, there are more than 400 patients registered, and in this register, we found some deficits or some limitations, and one is that some patients were not tested for viremia, and some patients were not tested for quantitative HDV RNA, showing that it's important to improve the access to diagnosis and the implementation of reflex testing. It's key for increase the diagnosis of hepatitis delta. Next. At the same time, the international guidelines started to recommend reflex testing or test all HBs antigen positive individuals for hepatitis delta. And in collaboration with different Spanish associations working on liver disease, infectious disease, and GI, we introduced in Spain the recommendation of reflex testing for all HBs antigen positive. Next. And using these recommendations, two different studies started in Spain implementing reflex testing. One is in all Spain except Catalonia, and the other one is in Catalonia. This is the Spanish study that includes almost 90 hospitals. And in this study, in this program, all HBs antigen positive in 2024 were tested for Delta. The rate of testing was very, very high, 85%, and reflex testing in those positive for viremia, 91% of reflex testing. And during this year of the study, 158 patients were identified. The majority were male and have advanced fibrosis. At the same time, next please, we started the Catalonia study, and the Catalonia study, it's in 7 labs. It covers all the population of Catalonia, and in addition to this reflex testing, and for me it's really important, there is a prospective register and linkage to care. Next. These are the results of the first year of the study. Again, an important number of people was tested. The majority of HBs antigen positive were tested for Delta. And during this period of time, we identified 68 patients with viremia. The majority of patients with viremia were born outside of Spain, so we have an important proportion of migrants, and about 45% have liver cirrhosis. And all of these patients were linked to care, almost all, 94%, and half of them started treatment with bulevirtide. So still have some barriers in linkage to care. The main barrier was lack of contact details, but the majority of diagnosed patients were linked to care. Next. So this is the data that we have on treatment, because you asked me to talk about treatment. Bulevirtide was reimbursed in Spain 1.5 years ago. And during this period of time, in this national register, that's include less patients than the total number of patients treated. We have in the register 125 patients treated with bulevirtide, and 60 of them with more than 1 year of follow-up. And clearly the register prioritized patients with liver cirrhosis. Next. So in summary, reflex testing for hepatitis delta has been implemented in many healthcare centers in Spain, helping to screen and allowing early diagnosis. However, this program does not cover all centers in Spain. Some private centers are not included. It is important to ensure the continuity of the program, and a high percentage of patients with hepatitis delta are currently receiving treatment with bulevirtide, mainly those with advanced fibrosis and cirrhosis, showing excellent tolerability. Thank you very much. I'm very happy to answer questions later.
Thank you. Incredible. And I do hope that you'll be presenting this on a lot more occasions, because it's such a fantastic example. I had no idea. It's brilliant, Maria. We do have some questions in a minute, and there's a few questions coming in the Q&A box. So we'll come back after our next presentation and ask the questions. So thank you, Maria. It does give me great pleasure now to introduce you to Dr. Tatyana Kushner, who's from the Weill Cornell Medicine, and country spotlight is United States. So pleasure to meet you, Tatyana, and welcome.
Well, nice to meet you, and thank you so much for the invitation to participate in this exciting session. It's hard to follow Maria's talk and hear about all of Spain's successes, but I think in the US we're making efforts to move in that direction as well, and I'll share some of our updates from the US perspective. So you can move to the next slide. Next slide. So I'll briefly go over the epidemiology of delta hepatitis in the US and what we understand and what we don't understand yet. And then talk about our current landscape of testing and screening for delta hepatitis. And finally, end on updates on our current approaches and opportunities in treatment of delta in the US. Next slide. So what is the prevalence of delta in the United States? So we have had an emergence of different studies trying to estimate the prevalence of delta hepatitis. And this is one study published a year ago that looked at a national diagnosis code-based database. And in this database, it was found that about 5% of patients with hepatitis B have delta. And interestingly, 70% of these patients with delta were just from 4 distinct states in the US, majority living in urban areas, and with some capturing of notable demographic features, such as that most individuals are white, non-Hispanic ethnicity, and had a lower mean income relative to patients with hepatitis B alone. But when you look at these types of studies, I think it's important to understand how this data is obtained. And in this particular study, it was obtained through diagnosis code. And so before someone puts in a diagnosis code for delta hepatitis as a provider, they need to be aware to test for delta, and then aware to about how to make that diagnosis. And perhaps the delta hepatitis is concentrated in these settings because this is where more awareness of delta hepatitis exists, and perhaps also because of certain demographic features, such as increased prevalence of patients from immigrant populations from areas where delta is more endemic. Next slide. This is another study also published this year, and this study took a different approach, where specifically laboratory data was analyzed. And Quest Laboratory Database is a national database that obtains labs from clinical practices from around the country. And in this study, they specifically tested hepatitis B positive lab specimen for delta. And in this study, they estimated a prevalence of about 2.2%. And among those samples that they tested, they found that 28% of the delta antibody positive samples were HDV RNA positive. And you would think that perhaps this is a more objective view of prevalence of delta, but of course there's also differences in where laboratory coverage is and where these samples are obtained as well. Next slide. And we've also had a few studies looking at a national database called the Veterans Affairs database, where in this database, the population is really mostly US born. There's not as much of an immigrant patient population within this data. And the benefit of looking at this type of database is that it's national and has coverage across the country. But of course, the patient population is unique in the sense that it is veterans in the US. And this is a study that we did over a decade ago at this point, looking at prevalence of testing for Delta and prevalence of positivity. And what we found is that less than 10% of patients with hepatitis B were actually ever tested for Delta. About 3% of these individuals were found to be positive. And when we looked at risk factors associated with Delta hepatitis positivity, we noted some interesting risk factors, including coexistent hepatitis C co-infection, alcohol abuse, and substance use in patients with Delta hepatitis, really highlighting the risk factors that we're seeing perhaps more in the US-born population compared to the majority of Delta hepatitis individuals in the US who are from immigrant patient populations. Next slide. And this is a summary of a few other studies that have specifically tried to estimate Delta hepatitis prevalence. What you'll see is that one of the studies from NHANES quoted an HDV prevalence of up to 42%, highlighting again, not that this is the true prevalence, and there have been many discussions about this study since its publication, but that there are different factors that affect our estimates, ranging from how we classify Delta hepatitis and also the assays that are using. And part of the critique for that study is that the assay used perhaps had a high false positive rate. But nonetheless, when you pool all the literature together, next slide, we're really beginning to understand that probably the estimate is actually quite similar to what we heard about in Spain of about 4%. This is a study from Robert Wong, which was a systematic review and meta-analysis that looked in the population in the US and tried to quantify the prevalence of Delta among foreign-born persons compared to US-born individuals, and pooling all the existing data to date found that overall the prevalence is about 4.2%. And again, that 84% of individuals with Delta hepatitis in the United States are foreign-born. Next slide. So how does this translate into our current practices and recommendations for screening for Delta hepatitis in the US? Next slide. So actually, in contrast to the different guidance documents that Dr. Buti just mentioned, in the US, we actually don't have recommendations currently for universal screening for Delta hepatitis, in contrast to recommendations from Europe and the World Health Organizations that really have emphasized universal screening. Our guidance from 2018 from the AASLD, the American Association for the Study of Liver Disease, have been unupdated since then and have specifically recommended risk-based screening for Delta hepatitis based on the risk factors seen in the table on the right. Next slide. And as we've learned in other health conditions with Delta hepatitis as well, risk-based screening is not necessarily so effective in picking up all patients with Delta. In this study, they looked at a retrospective cohort of 13,000 patients in 3 United States safety net health systems and found that among those individuals who actually met these AASLD risk criteria, only less than 5% were actually tested for HDV. So it's excellent to be aware of the potential risk factors, such as the endemic regions for Delta hepatitis that can lead to increased rates of Delta. But unfortunately, it doesn't translate to actual practice where screening is done in all individuals with risk factors. Next slide. But in the US, we've been moving forward with the our understanding and really our accumulation of knowledge to hopefully follow in suit to what has been done in Spain and other countries in order to move towards universal screening approaches perhaps in the future. And this study published this year was really a step in the right direction, where a cost effectiveness analysis was done specifically in the US, looking at whether it's cost effective to perform universal screening compared to a current screening rate estimated of about 13% in this study. And they found that overall, one-time HDV screening for all hepatitis B surface antigen positive adults and then subsequent treatment with pegylated interferon is potentially cost effective. Next slide. And so, although we don't have official guidance yet from AASLD, and this past week we were at our national AASLD meeting where new hepatitis B guidance was shared, and there was no update to Delta hepatitis screening recommendations. We did write a clinical practice update for the American Gastro Association where we specifically suggested universal HDV screening in all patients with hepatitis B, and really commented that we expect, that we hope that US guidelines may be updated in the future to reflect this recommendation. Next slide. In addition, we're also beginning to see efforts at implementing reflex testing in the US. This was our experience implementing reflex testing from hepatitis B surface antigen to HDV antibody in a US-based health system. And what was interesting is that, of course, we tested more individuals with Delta than prior to reflex testing, and there was a quicker time to testing. But I think what I do want to highlight is that it wasn't so straightforward. This process of implementing reflex testing took almost 5 years. We needed to get buy-in from multiple stakeholders, ethics approval. We obtained grant funding in order to actually cover testing for the first year that we implemented the testing. And so I think perhaps in the US healthcare system, or at least in our experience, it was a bit more complex with some barriers and challenges. But I do think that if we have national guidelines that are updated to recommend universal screening, perhaps this will become more straightforward. Next slide. So where are we in terms of treatment for Delta? Next slide. So as we've seen from Dr. Buti and other studies as well, we have now recognized that Delta hepatitis is the most severe form of hepatitis. And this is a recent study that was published looking again at the national VA cohort, again highlighting that patients with Delta infection had over 3 times and over 5 times greater risks of developing cirrhosis and hepatic decompensation, as well as significantly increased risk of hepatocellular carcinoma in this US-based population. Next slide. And so the updated AASLD hepatitis B guidance did acknowledge that Delta hepatitis is something that we need to really be vigilant about monitoring, and did make a clear recommendation that in all patients with Delta hepatitis, we should be screening for hepatocellular carcinoma, which is distinct from what we do for hepatitis B. So there is a recognition in the US that we need to monitor these patients more closely, and at the very least screen all of them for HCC. Next slide. And I'll end with just a few notes about our current approach and opportunities for treatment for Delta in the United States. So we currently have no FDA-approved treatment for Delta hepatitis in the US. And really, pegylated interferon is the only drug with any demonstrated efficacy that can be used off-label. And this drug is highly suboptimal due to significant side effects associated with it, as well as limited efficacy. Next slide. So what is the AASLD recommendation for treatment? So the recommendations say that pegylated interferon for 12 months is actually the current recommended therapy for those with active Delta hepatitis infection. They also comment on the use of nucleoside-nucleotide analog therapy, which really has no specific efficacy on Delta hepatitis, but can help with coexistent hepatitis B. And lastly, they say that given the limited efficacy of current therapies, it is reasonable to refer patients to specialized centers that offer access to experimental therapies for HDV. Next slide. And bulevirtide, which you heard about from Dr. Buti in the prior talk, although it has been approved in Europe for a few years now, we currently do not have approval for bulevirtide in the US, but we are very eagerly anticipating approval, hopefully in the coming year. And currently there is availability to access this in limited cases through an expanded access program. Next slide. So to summarize the potential treatment options that we have in the US, pegylated interferon can be used off-label but has limited efficacy. Bulevirtide is available through an expanded access program, and we hope that it will be approved soon. But we also have a few medications that are being actively evaluated, including in the US in phase 3 studies. So these are potential opportunities to refer patients for clinical trials in order to be treated for their delta hepatitis. Next slide. So I'll end here with a brief summary to say that delta hepatitis in the US is underscreened, underdiagnosed, and this does make epidemiologic estimates of true prevalence challenging. Risk-based screening for HDV is recommended, but I've shown that it's really not effective in identifying all patients with delta. So we hope that we'll continue to move and follow suit as to what we saw in Spain for universal screening. We've learned, including in US cohorts, that HDV is the most severe form of hepatitis and leads to rapid disease progression. And currently our treatment is limited in terms of efficacy, but we hope that in the not too distant future, we'll have other agents available with higher efficacy that are more tolerable for treatment of delta hepatitis. Thank you.
Fantastic, thank you. And do you know, I mean, I do think a tough act to follow after Spain, but there's some incredible work going on. And actually, when we look across the world, there's very little work going on. So I think you've got some incredible data there, and really interesting that the prevalence came back similar to Spain. You know, which again, yeah, very interesting. So we have some questions, or we have a little opportunity for a panel discussion if everybody would like to come back online. I've got a couple of questions, and then we're going to open it up to the audience. Is Fumi still here? Yes, yeah, okay. So I mean, maybe I'll start with you, Tatyana, and just see. So I guess I'm not going to do that. I'm going to slightly change it and maybe ask all of you first of all about the guidelines, because I found myself a little bit confused as we were going through, because all the guidelines are so different, you know, and this makes it really confusing. So who is following WHO, who's following EASL, who's following ASLD, you know, so I think Maria, it was in one of your slides, the different guidelines and the different guidance through them. I guess it's, how do we know which one is the right one to be following?
I can answer this question.
Yes.
I think usually EASL guidelines are followed by Europeans, American guidelines from people living particularly in North America. I think the guidelines are recommendations to push policymakers and insurance companies for the reimbursement of this test. In addition, at least in Europe, because in Europe we have a public health system in the majority of countries, are very useful for physicians. If physicians realize that this is important, they push the labs to do the reflex testing or whatever is the recommendation. So I think the guidelines are different, slightly different. Ones are more devoted to physicians, EASL for hepatologists, WHO more focused in low middle income countries. So there are slight differences, and this is the reason that probably they have different recommendations. At the end, all of them ask to test HBs antigen positive, at least with risk factors for hepatitis delta.
Yeah, and I mean, can I ask you, Jess? I mean, I know you were in a meeting where this was discussed around B and D, and there was some unanimous feedback within this meeting.
Yeah, thanks, Rachel. So on Sunday morning, actually at ASLD, we had a NoHep Medical Visionaries Forum, which was looking more at the hepatitis B guidelines, with the ASLD hepatitis B guidelines being released over the weekend. At ASLD, it was sort of a good opportunity to look at some of the discrepancies between the hepatitis B guidelines, but all of these guidelines also include Delta. And so we wanted to make sure we included that in the conversation. And it was very brief, but it also was overwhelmingly clear from everyone in the room that universal reflex testing is what people were saying we need. And I think that's the best way to scale up access and diagnosis rates quickly.
Yeah, I mean, I guess, I mean, Fumi, you were at the African Hepatitis Summit, and there was an incredible presentation on D, and what was really apparent in that meeting was it's the cost, you know, and I think you spoke about that, you know, it's the cost of the tests. So universal is not possibly an option for low middle income countries because of the cost, and for them, maybe it has to be about risk-based. I don't know. What do you think?
Thank you very much for the opportunity to speak. And, you know, I think that all the guidelines are complementary.
Yeah.
I think there is no one size fits all guidelines. I would like to flag that the WHO guidelines promote a public health approach, whilst other guidelines are from professional societies, and it guides the activity of specialists. So the focus is somewhat different, and I think that is important for guidelines. So depends on the context you're in. If you are in a developing country that has a greater burden, we have over 128 countries that follow the WHO guidelines. In a high-income setting, the approach is different. Again, the financing is different in high-income approaches. Lots of out-of-pocket spending in low-income countries. So we have the recommendation for both universal and for risk-based, understanding clearly that if countries start with risk-based testing, they can always scale up to universal. In many of the countries we work in, the laboratory capacity is not there. So there are no rapid diagnostic test kits for hepatitis D serology. And I think our approach has to be multi-directional. It has to be multiple different approaches to increase awareness, not just of the community, but of the healthcare workers. And you showed clearly that many healthcare workers from different parts of the world did not have sufficient knowledge about hepatitis delta. So there is a lot of work to be done for hepatitis delta, from screening, from strengthening laboratory capacity, laboratory systems, from standardizing test kits. The need for molecular testing is an added layer of complication, and there's certainly no point of care molecular testing. So there's a lot of discussions to be had. But the first step for us might be even countries understanding and having policies. If you look at many strategic plans in countries, they did not mention hepatitis delta. So that awareness and trying to support a public health response, the current response is not public health. Is very specialist driven and specialist subspecialty hepatology. So increasing awareness, scientific and innovative advances to make the test accessible and affordable are important. I'll stop there. Thank you.
Thank you, Fumi. I mean, brilliant. And I actually had a question written down here for Maria, which was, well, you got your hand up as well. So can I ask you your question and then you can feedback on that as well? Just what strategies, you've done it brilliantly in Spain, what strategies can be executed to increase public awareness and testing for hepatitis delta? You got your hand up too, so you got a double whammy there. Maria.
Yeah, I think to increase awareness, it's very important public education and awareness campaigns, as Fumi has mentioned. Campaigns like this webinar, the World Hepatitis Day, use influencers and community leaders. Having these webinars and all the material in different languages, it's really important.
Yeah.
You look at Spain, approximately more than 60% of people infected with Delta are migrants with Eastern European countries, of Sub-Saharan Africa, with language barriers and also with difficulties to access to healthcare system.
Yeah.
So having all of these awareness campaigns, peer navigators, screening at the community level. You cannot screen for Delta because we don't have point of care testing, but we can screen for B, and then we can educate patients with B to be tested for Delta. So I think there is room for a lot of actions. Reflex testing, it's also important. Everything that integrates means integration to existing health programs. It's really important. And in these community screenings that we are doing a lot for viral hepatitis, it's also important to include, or at least to talk on hepatitis Delta. And I would like just a comment on the prices. Prices, it's an issue, but I am sure that you remember at the beginning of hepatitis C, the tests were very expensive. So if we can start using tests and increasing awareness, I am sure prices will decrease.
Yeah, totally agree. Tatyana, did you want to come in there as well?
Yeah, I just wanted to add on, I agree very much. I think awareness and availability of testing is very important, but I think to the point of, Jessica's survey results, I think patient awareness for sure, but provider awareness arguably maybe even more, because even in our specialty settings with gastroenterologists and even some hepatologists who are just not focused on Delta hepatitis, there is actually limited awareness. And it's been very exciting to actually see at last week's AASLD meeting that actually the sessions on Delta hepatitis were finally full and people were asking questions and engaged. So I think we are moving the needle, but I think still it's a very select group of people that go to the liver conference. So I think we really need broader awareness. And to the point of the study that I shared about risk-based testing not working on a national level, people don't know what the risk factors for Delta hepatitis are. So I think if there are resources available, universal testing is an approach that can combat that. So even if you may not know enough about Delta hepatitis or have heard about it, that testing of all universal screening recommendations and reflex testing can really overcome that lack of knowledge.
That's brilliant. But what about as indicators for a clinician? What should a clinician look for to indicate that someone may have hepatitis delta? Is there anything?
There are some indicators, and it's interesting because generally speaking, individuals with Delta hepatitis have low hepatitis B levels. And so it's not uncommon for them to be kind of discharged from specialty practices or sent to primary care because they're labeled a hepatitis B carrier because their hepatitis B level is low when it's the Delta hepatitis level that's high. and that they may not have even tested for. So that's one key point. These patients may, if you don't test for Delta hepatitis, they may look like they have inactive hepatitis B. The other aspects to look at is that oftentimes these patients have very active inflammation, which is part of the reason why disease progression occurs so quickly. And so they may actually have very elevated liver enzymes. And oftentimes, again, they may have low hepatitis B levels, and providers are searching for other explanations. Could this be autoimmune hepatitis? Could this be medication related? But again, the knowledge that this is Delta hepatitis that could be leading to such high liver tests is really important. And the last aspect I would mention to some of the data that Maria shared, as well as us from the VA cohort, is that oftentimes these people are young, in their 30s and 40s, and they already have cirrhosis or liver cancer, which is not something that we commonly see at all in patients with hepatitis B or hepatitis C. So it is truly a very rapidly progressive disease in many patients, not all, but in many.
Yeah, and I think that's a really important point. I've just realized I've chaired really badly, because actually, Jess, I didn't get to answer your question, and we only have 7 minutes left for the audience to ask questions.
I think we should move to the audience then.
I'm gonna, yeah.
I think if people have heard enough from me, that's fine. I'd love to hear the audience questions.
Yeah, so if anyone would like to put their hand up, we have a couple of questions in the Q&A box that haven't been answered, but if anybody would like to put their hand up, and I think Ben or Viola will help me because I can't see the hands, and have a question for the panel, please do.
Currently no hands raised, Rachel, but as you say, there's a couple of questions in the Q&A, but if anyone does want to raise their hands, please do, and we'll unmute you.
Fantastic. Okay, so I think the first one's for you, Fumi. It says, thank you for the presentation. I'm from Mauritiana, a country with a high prevalence of hepatitis B and hepatitis D. However, we still lack diagnostic tests, both serological and molecular, for hepatitis D. My question is, what is the core role of WHO in supporting the strengthening of diagnostic capacities for hepatitis Delta in resource-limited countries? Tough question.
You know, that's a great question. And I'm going to start again, like I always love to start from hepatitis B.
Yeah.
Considering the fact that hepatitis Delta is done in people with hepatitis B. So I think in the first instance, there's a need to scale up hepatitis B testing in Mauritius. Hepatitis B, we have the test kits, we have the tools, we have the rapid test, we have everything we need for public health response, and that is not being done. So that's the first step. Now, when we come to hepatitis Delta, we actually do not have everything we need for public health response. We do not have a rapid point of test kit. And I think from a WHO perspective, the fact that we have testing guidelines in 2024 for us is a huge leap towards a public health response. So strengthening laboratory capacity, again, is health systems. Strengthen the health systems in the country, because most of the available tests now are laboratory-based tests. We're also talking with manufacturers for the development of rapid diagnostic test kits, and also having countries come for WHO pre-qualification so we can have standardized test kits. But again, that is some ways away, and cost is going to be an issue. So we're looking at human resources, we're looking at costing, we're looking at policy and multiple levels of support. And then we need to do the RNA testing. There is not great value if you have rapid testing. We've heard today that 20 to 60% of people with antibody positive may be RNA positive. So again, we need nucleic acid testing, and we're trying to stimulate the market for point of care development of standardized kits for hepatitis Delta. So we are ways away. Now the problem for low income countries, so having had a diagnosis, what next? Without access to treatment. So that presents an ethical dilemma. What do you do with the people that you have diagnosed and do not have access to treatment? At least we know that such patients can undergo more frequent screening, and we can begin HCC surveillance in such patients while we await developments in the field for the drugs. There's been excellent response with bulevirtide, and as WHO, we are actually collating evidence now, and we're hoping to have recommendations in the near future. I see a colleague from Mongolia who is also on the call, and that's one country where they are really doing a national-wide approach to both testing and treatment. So thank you.
Thank you, Fumi. And we have 3 minutes left. There is one question here on the EASL guidelines. I don't know, Maria, whether you want to take that one.
Yes.
You might be able to answer that. Can you see it? I'll read it. You have a look. EASL guidelines recommend monitoring hepatitis delta RNA every 6 months during treatment, at the end of treatment, after 6 and 12 months, and yearly for PEG interferon. Is a similar approach used in other geographies that you're aware of?
Thank you for the question. I think this recommendation is only in EASL guidelines because it's the only region where bulevirtide is approved. So there is no recommendation in American guidelines, no recommendation in WHO guidelines or PASL guidelines. Why this recommendation? Because we know that it's important to test during the first month of treatment, at least at year 1 of treatment, the level of viremia. And if this is undetectable, there is a subset of patients that potentially can stop treatment after 3 years of bulevirtide. In addition, for those patients who stop bulevirtide, it's important to monitor because some patients after stopping treatment can relapse, and this relapse is associated with an increase in viremia and in ALT, liver enzymes levels. And it's important to identify this relapse to reintroduce the drug.
Fantastic, thank you. And I'm so sorry, Tatyana, I'd love to come to you. We have no time left because I've done an appalling job at chairing this last section to actually talk more around this. But I guess what I just want to thank you all so much. I think this is the beginning of the conversation, of the webinars. I think this has been a fantastic way for the World Hepatitis Alliance to launch our first webinar within Testing Week. I'd, on a personal note, I'd ask both Maria and Tatyana, keep your information out there. Please present it in other places because so many countries aren't doing this. They don't have this, any research even. So I think it's really important that we keep it on the agenda. Awareness raising sits right at the top. I think, it's always going to be, we're all here because we know a bit more about hepatitis delta and we're really interested. We need to raise awareness, and I think that needs to be really high on the agenda. So thank you all so much for being a part of our first webinar. I wish you a great rest of your day, whether it's morning, evening, and watch this space for our next information around hepatitis delta. I look forward to seeing you again soon. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.